I am so excited that we have another episode in our Lipedema Awareness Month series. And we are so glad that you registered to join us. I see people logging on right now. They're all pretty excited because a lot of people want to get to know you better. Dr. Omar Beidas is our guest tonight and our presenter. He will be speaking on lipedema, evidence-based truths. Dr. Beidas, gosh, I met him over a year ago. I had seen some of his posts on Instagram at Dr. Body Contouring. And I thought he's intriguing because really in the Southeast, there aren't that many surgeons that I was aware of that are focusing on lipedema. And so I got to do an interview with him, and it was entitled, I Just Wanted to Help, which is the essence of what I came away from when I interviewed him. This is someone who didn't start out to treat lipedema, but encountered this patient population, and his heart was struck with the desire to help. And so you're going to hear a little bit about that today. I recommend you go to our YouTube channel, the Lipedema channel on YouTube, and look up the interview I did with Dr. Beidas to get to know him a little bit better as a surgeon and a medical professional. He is speaking tonight to us about the history and background information, stages and types of lipedema, why these are poorly defined, and as well as treatment options and more. I saw a preview of this presentation recently, and I had the privilege of meeting Dr. Beidas in person in Orlando, and I'm thrilled to welcome him to this forum tonight. And by the way, we know you're going to have questions. Feel free to please put them in the Q&A, and at the very end of the presentation, we'll go through those questions one by one. And let us know who's here with us in chat. Say hello. Let us know what city or state you're coming to us from. We're just really delighted that you're taking time out of your evening to be with us this evening. Dr. Beidas is a board-certified plastic and reconstructive surgeon. He is with Orlando Health Aesthetic and Reconstructive Surgery Institute. And if you were to look at all of his credentials, it would take up the rest of the time here. I see so many of our friends from the Lipedema Patient Roundtable and Dr. Heather Hedrick, who we have done webinars with in the past, Ian Walker Webster, so many people from Maryland, from Florida, from Houston, Nigeria. My goodness, Dr. Beidas, we have quite an audience tonight, which is super awesome. I want to say one other thing before we get started. Dr. Beidas started the Surgery After Weight Loss program at Orlando Health, the first of its kind in the Southeastern United States. So again, Dr. Beidas, we are so honored to have you. I am going to disappear and let you take it away with your presentation on lipedema, evidence-based truths.
Well, thank you so much for that lovely introduction, Brenda. It's an honor to be here. And thank you everyone who's tuned in. So as Brenda said, my name's Omar Beidas. And for those of you who don't know me or have not heard of me, I'm a plastic surgeon at Orlando Health. And as the name says, we're based in Orlando, Florida, with about 11 hospitals in and around Central Florida. So in today's talk, we're going to start out with some history and definitions for those of you who are new to lipedema, then talk about some of the classification schemes, treatment options, and then I really want to focus most of the time on evidence-based medicine and what the data shows, because I think there's a lot of myths out there about lipedema, and I often get asked questions when patients do research online, which can sometimes do more harm than good. And I think there's a lot of misinformation out there. So starting out with some history. So lipedema is known as two-body syndrome. It is a loose connective tissue disease. And it's a chronic progressive disorder, meaning it is essentially lifelong and unfortunately only worsens. It doesn't get better on its own. And the interesting thing is that it's very variable from one person to another and has a very unpredictable clinical course. It can affect any area, but most commonly we'll see that it affects the limbs, so the upper and lower extremities, typically sparing the feet and the hands. the buttocks, hips, and then finally the abdomen. So looking at some history, lipedema was first described by Allen and Hines at the Mayo Clinic in 1940, so a little over 80 years ago. It took about 11 years for the first paper to be published, and there was actually a male included in that publication. And then for about 40 plus years, only one other paper was published in English, so up until 1994. And that paper was in 1984. Interestingly, in 1994, the first article was published in our big, we call it the White Journal, the Plastic and Reconstructive Surgery Journal. And that's the journal that all of us as plastic surgeons typically subscribe to. In 2002, so about 20 years ago, the 20th World Congress of Dermatology was held in Europe, and the first results were reported about tumescent liposuction, which was actually the Klein solution, which we use, is actually invented by a dermatologist, interestingly enough. Later that year, liposuction was used by the Hans Clinic in Germany, and in 2004, the second report of a male patient was published. It's kind of just some landmark items there. A little bit of boring information here, but in terms of histology, I won't spend too much time on this, but a couple of interesting points. We see these crown-like structures in this bottom left slide here. So kind of flip this upside down and you can see how this looks like a crown here. And that's what those crown-like structures are, is essentially an adipocyte, which is a fat cell surrounded by a macrophage, which is a cell that engulfs other cells and disposes of it. And so you have the CD68 plus proliferation on staining, and then you also have proliferation of Ki67 and CD34 adipose-derived stem cells. In terms of pathophysiology, it is very multifactorial. So we see a microangiopathy, which leads to an increased permeability of proteins, meaning proteins are able to get into to travel in and out of the blood more easily. And that leads to increased capillary fragility, meaning your blood vessels, those small blood vessels, are called capillaries, and those become more fragile to injury. And that's what causes the easy bruising, or at least what's believed to cause the easy bruising in lipedema. Then we have hypoxia, which is low oxygen levels, which leads to angiogenesis, which are new blood vessels. And an interesting study found that in a lipedema patient, there's an average VEGF factor, which is a growth factor that leads to growth of vessels, about 4 times that of a normal patient. We don't really know what causes that, but that was an interesting finding. And so in untreated lipedema, essentially you have this vicious cycle of fibrosis and inflammation driven by angiogenesis. And so you can see here on the slide, if you have increased tissue compliance, if you kind of start on that top right, leads to more tissue fluid, more inflammation, more adipocyte hypertrophy, meaning fat cells growing, angiogenesis, and then fibrosis. And of note, for any non-medical professionals in joining us, after adulthood, the number of fat cells we have typically don't increase. The way we gain and lose weight, or fat cells gain and increase, is actually by hypertrophy, meaning the cells that you have grow larger and don't actually increase in number. So in terms of diagnostic criteria, the big things are going to be that it's present almost exclusively in women. It is bilateral and symmetric. There's no to minimal pitting edema. There's pain and tenderness with pressure, easy bruising, and then persistent enlargement despite weight loss. Not necessarily that the legs are growing, but that the legs stay large despite weight loss. To my knowledge, there's only about 2 case reports of male patients, and both of those patients, I think if I remember correctly, had some kind of hormonal issue. I think one had a liver problem, and the other one was receiving hormonal therapy for prostate cancer. So again, that kind of validates the fact that it is very hormonally driven. In terms of symptoms, one study, and I thought this number was interesting and a little depressing or sad, I guess, as that diagnosis was made for a patient after visiting an average of almost 3 doctors, ranging from 1 to 20. So patients are having to see, unfortunately, many physicians before being diagnosed, and that's certainly something we need to change going forward. But in terms of symptom presentation, almost 9 out of 10 women have pain or pain with pressure. Again, a large majority have easy bruising. Almost 3/4 have a cold sensation, and then about 1/3 have numbness or burning sensation. No patients have no complaints, which is one of the important findings that came out of the study. So in terms of etiology, or what causes this condition, it's unfortunately unknown, and we need much more research to find the etiology of this condition. But certainly there's a strong family history based on studying patients that does suggest a genetic basis. There was a study that looked at 6 families and 3 generations of patients with lipedema, and the inheritance pattern was found to be autosomal dominant with incomplete penetrance, which is a little interesting that it's only found in women, yet it was not linked to one of the sex genes like the X and Y chromosomes. In terms of hormonal factors, as I said earlier, they do play a big role, and the initial manifestation of lipedema or its exacerbation, meaning its worsening, will typically arise in a hormonal change. So for women, the big ones are puberty, pregnancy, and menopause. But I've seen it happen in women after a thyroid imbalance. PCOS is a big one, but again, that's hormonally driven. After surgeries such as thyroid surgery, parathyroid surgery, or hysterectomy, for example. So for anyone here wondering whether they have lipedema or lymphedema, it really only takes a good history and physical exam to be able to differentiate the two. There's really no need for imaging, but I'll get into that on the next slide. Essentially, again, lipedema will typically only be present in women. It has a common family history. Cellulitis is rare. It is almost always bilateral. The feet are almost never involved. You do typically have a fat pad over on the ankle bone called the malleolar fat pad. The swelling is soft. There's rarely pitting edema unless there's a component of lymphedema, which can happen, and tenderness is very common. And these are all opposite to lymphedema, a patient with a history of lymphedema. Again, as I said earlier, testing is rarely required. For example, I think I probably order a lymphoscintigraphy study on less than 10% of patients who I see with lipedema. And again, those are the ones who may have a component of lymphedema. But if you do get testing, or if you've had testing for one reason or another, on a CT scan or MRI in someone with lymphedema, what you'll see is dermal and subcutaneous tissue thickening, meaning thickening of the skin layers and the fatty layers. Whereas in lipedema, what you'll see on CT or MRI is fatty hypertrophy. So fat cell hypertrophy throughout the lower extremities, but no skin abnormality. So some comorbid conditions, meaning things that accompany lipedema, as I just stated on the previous slide, lymphedema is one in the advanced stages. Obesity is commonly found in lipedema patients, so we call it non-lipedema obesity. Venous disease is very common, and actually many vascular medicine or vascular surgeons will diagnose patients with lipedema. Joint disease, and then hypermobility. In terms of patient complications, the most common things that we see most certainly are decreased mobility and activity as a result of symptoms and pain, reduced overall health, and that can include mental health, difficulty finding properly fitting clothing because of the discrepancy in the waist, hips, and lower legs, and certainly embarrassment. Again, that goes along with some of the mental health issues. So how do we classify all this information? We'll spend a little bit of time on this because, as I'll explain later, I don't think it's the best. We have the best systems in place. But lipedema is typically classified into 4 stages. They're illustrated on the slide. So in stage 1, the skin is smooth and looks normal. In some cases, people might even ask these patients, are you sure you even have lipedema, or whatever this condition is, if they don't know what lipedema is. In stage 2, we'll start to see a little bit of uneven skin, maybe a little bit of dimpling. Stage 3, you'll see these larger lobules or extrusions of fat. And in stage 4, the patient doesn't necessarily have to look like the patient in the picture, but stage 4 typically is presence of lymphedema. And really anyone can develop lymphedema. I would say it's much more rare in someone with stage 1 than stage 3, or someone who looks like a stage 1 person versus someone who looks like a stage 3 person, but it can happen in any one of these women in these pictures. I think, unfortunately, this is a bad system because typically stages will guide treatment, but the treatment for lipedema, as we'll get into, is really the same for all of these women, barring maybe the stage 4 on this slide. The symptoms are subjective, the symptoms and the degree of subjective symptoms do not correlate with the disease stage. So you can see a woman with stage 1 who has extreme tenderness to palpation versus a woman in stage 3 who has a minor tenderness to palpation. So staging, again, might be helpful in knowing stage 1, what they look like, but it doesn't really indicate the progression to someone with lipolymphedema, and again, doesn't really guide treatment. So kind of along the lines of what I was just saying, the disease progression varies greatly. Symptoms will stabilize in some patients, meaning they don't progress over time, or you have gradual progression of symptoms, and then you have exacerbation that's provoked by stressful situations. And we see all 3 of these, and you can shift from one of these bullets points to another, even in the same patient. And there's no data to suggest that everyone progresses through all the stages. So again, the stages are not really that helpful of a classification scheme. So the next classification scheme that we have is by types. So many of you probably know this already. Types are not, they refer to the anatomical location of tissue, and therefore a patient can have more than one type. Again, I think not a great system. Types are typically mutually exclusive, whereas in lipedema you can have a combination of types. So I think that can be a little confusing. But regardless of that, again, I said the treatment's the same for pretty much all the stages and all the types except maybe stage 4. So how are we going to treat these patients, and how will we help patients? So there's 2 main types of treatment. Looking at a big picture, the first one is conservative or non-surgical, and then the second one is surgical, which we'll get into a little later. For the conservative treatment, our goals are really to relieve symptoms, because we tell patients really there's not going to be a big change in the appearance, because the purpose here is just to try to get control of the symptoms. There can be a small, less than 10% of a reduction in tissue volume with conservative management. Most likely that's whatever little fluid is there being helped with the compression and the pumps. And their studies have shown that there is a decrease in tenderness, which is pain on pressure, and a feeling of tightness in the limbs, which is probably one of the most common complaints that we hear, is a tightness or a heaviness of the limbs from patients. The next conservative treatment is diet and exercise. Starting with diet, really no good evidence-based data. You'll see all kinds of information online, low salt, anti-inflammatory, some of these enzymes and vitamins. I don't know that any of them have a whole lot of data behind them, specifically for lipedema patients. In terms of exercise therapy is really geared to either maintain weight or in an attempt to lose weight in preparation for surgery, or in an attempt to lose some of that non-lipedema fat. So the exercise therapy should really be tailored to the patient's needs. The most beneficial types of sports will be those that are controlled, cyclical types like walking or running, movement that activate the calf muscle, but don't cause any trauma to the tissues. Because the pressure gradient underwater does help decrease edema, aqua jogging or aqua therapy, aqua gymnastics is really a good group of activities for patients with lipedema to do. And it does put less stress on the joints in patients who are overweight. The next group of conservative treatment options will be garments and physical therapy. So compression, pneumatic pump treatment, and deep tissue therapy or massage. CDT or complete decongestive therapy will include some of these things like manual lymphatic drainage, again, compression, PT, and then a skincare and exercise routine. Compression therapy, a lot of patients ask if they have to wear it. Certainly, I think it's an important part of the bundle of treatment, shall we say, for lipedema. It is unlikely to reverse symptoms, but it might help prevent worsening and progression to lymphedema or lipolymphedema. We require patients in our treatment area to use compression postoperatively. And typically we tell them it's something they may have to use for life, although perhaps as they get farther and farther away from their surgery to a lesser extent. So in terms of adjunct treatments, we get a lot of questions about this in our clinic. The CoolSculpt and the J-plasma, known as Renuvion. And again, in terms of evidence medicine, there's no data on any of these modalities, and this, either no data or no good data. So patients will ask about cellulite reduction. I've put some of the brand names in parentheses. Ultrasonic cavitation, cryolipolysis, and none of these have any good data to support them or for us to recommend them. In terms of pneumatic pumps, the purpose of these, some of the brand names, Lympha Press is one of them, for example, or FlexiTouch, but Lympha Press is the only one that is FDA approved for lipedema, and that's the one we typically recommend in our clinic. So the purpose of these pumps is to stimulate the connective tissue to mobilize fluid, decrease fibrosis, and these have been found to be maximized after exercise. So moving on to the surgical treatment, as I mentioned a little bit earlier, there's really two types of surgeries or operations that we do for lipedema. So the first one is suction-assisted lipectomy, or liposuction for short. And since 2005, liposuction has been included in the German guidelines for lipedema. And then there's excision, which is typically skin excision plus minus lipedema excision. And to prevent relapse or recurrence, typically what we try to do is remove as much as possible of the layer of fat beneath, or layer of tissue, I should say, between the skin and the muscle. However, we have to keep limits of safety and cosmetic consequences in mind. The assumption is that after surgery, if we remove all the fat between the skin and the muscle, or the skin and the fascia, that no new cells will be formed, or at worst, the few remaining cells will only cause minor visible tissue growth and symptoms. And then, as I said a little bit earlier, over a longer period, meaning 6 months, 1 year, 2 years after surgery, conservative treatment should either be able to be reduced or terminated in the vast majority of patients. And I'll show some data from other studies a little bit later in the presentation. So evidence-based medicine, kind of the purpose of this talk, what does the science say? So kind of as I alluded to earlier with the history, really very few papers were published. So this is a timeline from 1951, and I looked this up about 2 months ago, so this is accurate until this year. This was the first paper. These here are actually nothing, but they kind of look like there was something published, but there's nothing. And then again, you have one here and random sporadic ones. So a lot of the papers were published, looks like in the last 10 years. And even then, of these, there's really no good high quality studies. Problems being a low number of patients and then no good validation tools. Unfortunately, I think, at least in the US, many of these patients are treated at private centers instead of big academic centers where research is typically done. And therefore, it's just difficult it's very difficult to get research data on these patients. You'll see a resounding theme here in some of these papers. So the first paper, this is in our PRS, our white journal. It's a survey in Germany. They polled 209 patients, aged 20 to almost 70. In this paper specifically, everyone was stage 2 lipedema. So again, very subjective finding or determination. And everyone was treated with liposuction. So in terms of age at onset, you can see most patients onset around puberty, so 14, looking at the left side of the slide here. And then it starts to go down as women age. There does seem to be another, I don't want to say peak, but almost kind of a second peak in the mid-30s. And I think that has to do with maybe pregnancy. And then another little peak here in the 50s, and I think that has to do more with menopause. In terms of years until diagnosis, again, kind of depressing data, many people waiting 15 years or more until they're diagnosed. Again, we said this is familial, so there is a genetic link, and you'll see, several, the majority of patients have a mother who's affected, or has their mother affected, an aunt, almost half the population, and then one grandmother was almost 3/4 of the population. In terms of surgeries, the vast majority of these patients required 1 to 5 surgeries. I wish they kind of broken this up a little more. About 20 required up to 10, and then it looked like, I think one, if I remember correctly, required 17 surgeries or some high number. And then you can see here on the right the breakdown of body parts. So in terms of outcomes, this breaks down conservative management before and after surgery. So on the top part of the slide, we have lymphatic drainage. Before surgery, the majority of patients, if you look, were getting it 2 times a week. Whereas here you can see the majority has gone to none to 1 time a week, and no one was getting it 4 times a week after surgery. In terms of compression, before surgery, the vast majority, 90%, were using compression before surgery, whereas only about half were using it after surgery. Another survey, again in PRS, again out of Germany, 106 patients who underwent 298 surgeries, so almost 3 surgeries per patient on average. This one included all stages except for patients with lymphedema. Again, all these patients are treated with liposuction. And this paper had a 10-year follow-up. So in terms of data, the amount of lipoaspirate per surgery was a little over 6 liters. The amount of lipoaspirate overall, again, per patient, almost 18 liters. Number of operations, as I said, on average was almost 3, and they did about 300 surgeries in total. So again, in terms of conservative management, patients who no longer needed compression garments overall was 35%, and they divided their comparisons into stage 1 and 2 versus stage 3. So you can see here, stage 1, 2 patients, almost half, let's say, 40% no longer use compression after surgery. Stage 3 was much lower at 20%. In terms of conservative therapy in general, 25% no longer needed this after surgery. But again, the stage 1 and 2 patients fared a lot better. About a third stopped conservative management after third surgery, whereas less than 10% of stage 3 patients were able to do the same. This is a bit of a busy slide, but this is looking at symptoms before and after surgery. So typical complaints of lipedema, we kind of talked about these earlier: spontaneous pain, sensitivity to pressure, tension or tightness, bruising, and then some of these are mental body image general impairment. Many of these, if you look, so this is going to be before and after for each one of these 6 symptoms or 6 measures. And you can see a significant drop from before to after for each of these. So you look at the kind of the middle of the bar here to this bar. So many of these were rated as very severe preoperatively, or 80 on a visual analytic scale, and many of them improved significantly. And this was all statistically significant. Looking at BMI and size of garment, so BMI is over on the left side here in the white boxes, size of garment is on the right side. There was a significant decrease in BMI by almost 3 points from before surgery to almost 3 years after surgery. And in terms of garment size, there was a 2 garment size drop, and that was in European measurements. So one of the things I hear a lot from patients is that higher liposuction volume means that I'm going to have a better improvement in symptoms. And a lot of patients, I feel like, fixate on the volume of tissue removed, and I always tell patients the volume has no bearing on how well you do. So true or not? This study, this same one that we were just talking about, actually found no correlation between the amount of lipoaspirate and the reduction in CDT or improvement in symptoms. So I thought that's an interesting finding, and I think it's the only paper that's found that. And these things actually were adjusted for BMI or body mass index, body surface area, as well as body weight. And they still were unable to find a link between volume and improvement in symptoms.
Dr. Beidas, can I interrupt you 1 second?
Yes, of course.
I am holding questions until the end, but one of our participants asked what CDT is. For those that aren't familiar with that acronym, could you just explain that real quick?
Yeah, so that is it's decongestive therapy or complete decongestive therapy. And that is the combination of, on that slide I showed earlier, I can go back. It's the combination of MLV, pumps, the compression, skincare, and exercise. So it's all these things together. And the goal of that is to get rid of as much fluid as possible. The compression therapy helps with that, as well as also desensitize the skin to some degree. Desensitization is a funny term, and I think the best analogy I can tell people is think of, if you put your watch on in the morning, and the minute you put it on, you can kind of tell that it's there, but an hour later, you don't realize that you're wearing it. So that's kind of the same thing with compression, and getting your nerves used to that feeling of compression, and your symptoms typically will get better over time.
Thank you.
So it's just getting the nerves adjusted.
Perfect.
Great question.
Yeah, I didn't want them to get stuck on that acronym and miss the rest of what you're going to talk about. We have people from all different levels of expertise on tonight's webinar, and we want to make it understandable to everyone. And boy, we got some good questions coming in too. So I will let you keep going.
No, interrupt as needed. It gives me a chance to hydrate.
Good.
Right, so here we're saying there was no difference in the amount of CDT reduction, meaning no difference in the amount of compression therapy, or let's call it conservative management. So there was no difference in conservative management with the amount of liposuction performed, volume. So then that begs the question, what factors did affect outcomes? So looking at stage 1 and 2 versus stage 3, there was a significant difference in analog scale score. So that's those 7 symptoms we talked about. So patients in stage 1 and 2 had a larger percentage reduction in CDT score than patients with stage 3. And then as well as the 7 symptoms we talked about. And then the other factor that affected those two same outcomes was a BMI less than 35 versus a BMI greater than 35. So you can see in patients with a BMI less than 35, their visual analog scale scores, and again, those are those 6 symptoms: pain, pressure, tension, mental health, general health, almost a 50% reduction in a patient with a BMI less than 35, and maybe about 25% reduction in a patient with a BMI greater than 35. And it's much more striking when you look at CDT scores. It's greater than 60% difference in a patient with a BMI less than 35. And I think this was like 3%, a little under 3%, if the BMI is over 35. So that just kind of repeats that same slide. And again, these numbers are statistically significant. So stage 1 and 2 does better than stage 3, and BMI under 35 does better than BMI over 35. So this was another paper, again, out of Germany. Like I said, there's kind of a theme here. We don't have a lot of data from the US. This one was 85 patients. It was actually a follow-up study. So they looked at patients at 4 years and then at 8 years. And then they evaluated 7 items, which were very similar to the 6 that the previous study looked at. So spontaneous pain, sensitivity to pressure, swelling or edema, bruising, movement restriction, cosmetic impairment, and then quality of life reduction. And again, another busy slide, but the takeaway is on all 7 of these items, apart from the spontaneous pain, so you have the left column here is before liposuction, so pre-op. 2010 was their 4-year follow-up, and 2014 was their 8-year follow-up. So again, apart from spontaneous pain, which is that first row, between 2010 and 2014, there was a slight increase in all these numbers, whereas spontaneous pain stayed the same. So you might think, well, what's the point of doing surgery if I'm going to get worse? But regardless of the fact that it worsened a little bit at the 8-year mark compared to the 4-year mark, all these numbers are still much lower than their numbers before liposuction. So everything's better at 8 years, but it's a little worse than it was at 4 years. And that's something I think that's important to stress to patients. And I tell all my patients that typically you're not going to stay great for 20, 30, 40 years. I tell patients typically the younger you are, the worse this will get as time progresses. And again, that just goes back to this being a chronic progressive disease. So another myth I hear a lot is, I should stop saying these are all myths. Another thing I hear a lot from patients is that lipedema does not respond to weight loss or bariatric surgery. And so, lipedema tissue is not normal fat. And the reason it's important is that lipedema is resistant to diet and exercise. But does that mean that all patients with lipedema cannot lose weight? Absolutely not. So, weight loss or bariatric surgery, it is ineffective in uncomplicated lipedema, and that's lipedema without obesity or lymphedema. Again, we know that lipedema is resistant to diet and exercise. However, it is effective in lipedema that is associated with obesity. And so one of the things we talk a lot about is, why is lipedema removal difficult? So lipomas are non-encapsulated and infiltrate surrounding tissue. But if you look at lipedema, it's really difficult to distinguish from subcutaneous fat and other healthy tissue. And so this dense and fibrous composition of lipedema makes it really difficult to aspirate the fatty tissue in a conventional way. And there are studies out of Europe that have shown a significant reduction in patients with high BMIs with weight loss surgery. So another thing I hear a lot from patients is that water-assisted liposuction is less damaging to lymphatics than other techniques. And we sometimes have patients coming in to our clinic saying, well, I want water-assisted liposuction. So what's the data on that? So these are 2 papers. Neither of them is great. Again, none of these papers have 600, 1,000 patients. But there was one paper looking at 50 patients undergoing suction-assisted, this should say lipoaspiration. But essentially, traditional liposuction with a vacuum. and they performed a lymphoscintigraphy before and after liposuction, and it showed a slight improvement in lymphatic flow. However, this was not clinically significant. But basically, their conclusion was that traditional liposuction didn't damage the lymphatics. Another study looked at 30 patients, and they did water-assisted liposuction. And they, rather than doing imaging, they looked at, they analyzed the fluid of the lipoaspirate under staining, and it showed minimal evidence of lymph vessel structures. So this paper in red, to me, that doesn't really mean that there's no lymphatic injury, but people took the results from the study to mean that water-assisted liposuction is better than any other form. You know, I'll say I can't tell you that that's not true, but it's not really founded in evidence either. So as far as we know, there's not really one technique that's better than any other. So in terms of risks, I think the main ones and the ones I typically talk about with patients, I kind of break them down into two. So we have two treatments. On the one side, we have liposuction, bleeding as with any surgery. Pigmentation changes are probably the most common thing that we see, especially with large volume liposuction. You can get pigmentation changes or changes in the color of the skin. So you can get lighter skin or darker skin. And then finally, contour irregularities. And this is true of a woman who's having liposuction for cosmetic purposes, but it's more true for someone with lipedema because most women with lipedema don't have nice, smooth skin. And so that's just one of the things that comes along with having that condition. When we talk about excision or skin removal, in my experience, by far the most common complication is having the wound breakdown. But again, by far of those patients, the wound breakdown is small and can be covered by a Band-Aid or a gauze. Adverse scarring, meaning you can have hypertrophic scarring or widened scarring. And then skin laxity or recurrence. And that's more true in really two populations, either the really advanced patients, stage 3, who have really big folds, or patients who've had weight loss and have a lot of loose skin. So here at Orlando Health, I'm going to go through our protocol and talk about how we treat patients locally. So it is very reliant upon teamwork, and I'm very fortunate to work with a great team of physicians, therapists, dietitians, and we're looking to get psychology involved. I'm actually in communication with one of our psychologists to get them on board, hopefully later this year. But our team is basically the patient's PCP. We get clearances on every patient. We'll touch base with the endocrinologist if they have one. There's the plastic surgeon, myself, our physical or occupational therapist, again, dietitian and psychologist or psychiatrist. And so it's really important for these patients to understand that there's a lot of preparation that goes into the pre-op process. So we want to make sure patients have their compression garments and they're lined up, their pumps, they're on an appropriate diet. Again, there's not much evidence on that, but we suggest an anti-inflammatory diet. And then we want to manage expectations. So surgery, what does that look like? Typically, it will be a multi-stage treatment. As you saw on one of the slides, most patients will have anywhere from 1 to 5 surgeries, with a few requiring more. We recommend compression garments 24 hours a day for 6 weeks, except when showering. We start MLD 3 days after surgery, and we continue that for 6 weeks. Surgeries are typically 3 or more months apart, and our goal is for 10 to 15 liters of lipoaspirate per session. Again, as long as there's not a lot of bleeding, as long as the vital signs are safe, that's our goal. I do these in the hospital, not at a surgery center. And then the last stage or last surgery of that multi-stage treatment is skin removal after appropriate debulking. So this is one of our patients. She presented to us. She was 66 years old. This is her in the OR. And this was her after 10.5 liters taken off from her lower extremities. I believe we've done her thigh-plasty or skin excision, but that was recent and I don't have up-to-date pictures for her. This is that same patient. treating her arms. So we did liposuction and then skin excision. And again, I warn patients the most common area on the arms is to get a wound breakdown in the armpit. There's just a lot of motion there, and it's typically the tightest area of the closure. This is another patient. Here's her before and after, left and right, and then again left and right on the other half of the slide. So we did, at this point, 3 surgeries on her, and almost 18 liters removed over those 3 surgeries from her thighs and legs. So you can see a major difference. And we've actually, I believe at this point, done her skin excision. You can see part of that scar here on the left thigh. We've actually done one more surgery since then, but again, I don't have, she's not far enough to have pictures. But we did one more surgery with more liposuction and then did a horizontal excision of her thigh. And then into the gluteal fold here. So really to lift that tissue and not so much just reduce the thigh. Another patient before and after, treated abdomen, buttock area, and thighs. And this is the same patient again after treating her arms. This was one patient. This was a 42-year-old. We did so far 1 stage, almost 18 liters from the entire body. But these are her pictures. She's from out of town, so we don't have nice clinic pictures for her, but she was kind enough to share her pictures with me. Those are her thighs before and after. So complications, like I said, these are not without complications, and I'm very fortunate to have a great team. So this lady showed up in my office, I think maybe 1 week after surgery. And as I said before, the common area to get these wounds in the arms are in the armpits. But this lady had been in inappropriate compression. And so she also broke down in other parts. So she broke down along the several parts here on the right arm and several parts here on the left arm. And that's really unusual. So I actually saw her in clinic. I immediately called one of our therapists, the therapist who was seeing her. And I told her, we have to get her in good compression. We'll take care of the wound care and the wound care regimen, but I really need her in better compression. And so again, it's that close relationship which allowed us to get from here to here in about 3 weeks. Which for these, if this was a wound otherwise and there was no close relationship, this could have taken months to heal. And 3 months later, this is what her scar looks like. And I'm not really sure what these Band-Aids are for, because I'm pretty sure she was healed at this point, but maybe she had a spitting suture. So in terms of takeaway points and important things to keep in mind, again, the pathogenesis is unknown. The treatment is palliative, not curative, meaning there's no cure for this condition, at least not as of yet. In terms of goals, the goals for treatment are recovery of function and to some degree improved appearance. And then again, I can't overstress the importance of teamwork. I don't think we would be where we are at Orlando Health without a really good team of providers. And I think one of the biggest takeaways and one of the things we've learned in our team is one of the most important things that will help lipedema patients is likely what Allen and Heinz suggested back in the 1940s, which was emotional support and reassurance. So thank you for tuning in, and Brenda, I guess you have a long list of questions for me, so.
I have questions coming in, not just in the questions, but also in chat. And I also want to acknowledge that we have some of the authors, including the lead for the standard of care of lipedema in the United States, Dr. Karen Herbst, has logged on. I don't know if she can be on camera. Oh, there she is. Hi, Dr. Herbst. She's also our Chief Medical Officer at Lympha Press. So we're delighted to have you here. Before I get to all the other questions, may I yield the floor to you, Dr. Herbst, and see if you have any comments that you would like to make. And first of all, thank you, Dr. Beidas. That was very comprehensive and very good. Thank you so much. Go ahead.
I thought it was clear, comprehensive, kind of took our hands and walked us through everything. I thought it was really terrific. I just had one question for you. I hate to barge in line, but you were talking about diet studies. So there's 2 diet studies that I know of that are out. One's on a low carb diet, and the other one is on, like a keto, and the other is a Mediterranean. And the Mediterranean diet showed that women with lipedema could lose weight, but they didn't lose percent fat. And then for the keto diet, it was a very small number of women, it's like 9, and they did lose weight nicely, but their pain stayed. And same thing with Mediterranean diet, no decrease in pain. So I thought that was kind of interesting.
You're right. And I mean, there are studies, and I guess my point is that not many good studies, just a small sample size. But to your point, we're starting to have a dietitian referral, a requirement for our protocol here. And the dietitians we've spoken to actually have kind of preferred the Mediterranean diet, I think, and that's probably the one. We're kind of still working the protocol out, but I think that's the one they're going to ultimately recommend to patients. Unless you think we should recommend something different, because
I'm good with your nutritionist and what they recommend.
Yeah, and I appreciated the discussion about the comprehensive approach. There are many tools in the toolbox to help manage lipedema. Of course, Lympha Press being the sponsor of this webinar, I was delighted with your section on pumps, and we do have some questions about that from the audience. I also want to recognize Kathleen Lisson is out there, Linda Ann Kahn, some of the colleagues on the standard of care paper. We're so honored that you're with us tonight. And there was some buzz about your question or your statement regarding the compression for the upper extremity. Someone was seeking clarification. Kathleen Lisson and Missy were also seeking clarification on that. What kind of compression was it? I believe
what kind of compression was? I'm trying to go through the chats to see where.
I know there's so much chat coming in.
What type of inappropriate compression? I don't know if she was compressing inappropriately or not elevating enough, or maybe a combination. I can't remember, to be honest with you, at this point. And then I see someone else ask what was the better compression. And again, I don't know. It might have just been her not elevating enough, or if she stopped using compression because she was swollen, and then we just had to re-educate and tell her, no, you have to be in the compression so that we treat the swelling. And she might have been at that point so far swollen that she couldn't fit in her regular compression, and that's why I got her back in with her OTPT. I actually think Dawn answered or sent a message here, so she might be able to, if she remembers, she might be able to chime in here. But I don't remember the exact circumstance, so I'm sorry.
I actually have been loving the chat because people are swooping in and answering questions before we can even get to them. And it's just a very vigorous conversation that's being had here, which is wonderful. Let me get through some of these questions. First, an anonymous attendee asks, how do you feel about some of the major complications that come from lipedema treatment, like necrosis? She clearly says, I am scared, and we feel for you.
How do you treat them? Was that the question?
Yeah, how do you feel about the major complications that come from lipedema treatment? And you did address some of those complications in your presentation, but I didn't know if you had anything you wanted to add to that. This came in very early in the presentation, and perhaps the question has been answered, but I thought I'd pose it again.
How do I feel about it? I mean, I wish it didn't happen, but the truth is, anyone who does enough of this will tell you that there's always complications. And I think lipedema, especially because of the large volume, again, it's not cosmetic. So because of the large volume lipoaspiration that we do, I think that even puts patients at a higher risk. So I would say if you're considering surgery, definitely don't seek someone who has very little to no experience with lipedema. So I would not go to the cosmetic surgeon down the street. And then I think, it always helps if there's someone locally. In my experience, the patients who are here, in Florida, whether it's an hour, 2 hours, or 3 hours away, are a lot easier to treat than the patients who come from, a 2-hour plane ride and then fly home 2 weeks later. We do recommend for out-of-town patients that they stay for 2 weeks after surgery. Typically, that will get us through or get you through any major complication, and hopefully it's none. But that way, at that point, we know whether there's going to be a problem or not, and then we can make you extend your stay if needed. But certainly with the lack of surgeons and the lack of treatment centers in the United States, it's not possible for everyone to find someone locally. So, if you are going to travel, I would say make sure you're in town for, whatever the doctor recommends or whatever the surgeon's comfortable with.
I love the comment that just came in from Kathleen Listen. She says, do period, not period, price period, shop period for this surgery, find an expert. And definitely underscore and highlight that and completely agree. And I'm sure you would as well, Dr. Beidas.
100%.
So Dr. Heather Hetrick, who we have worked with in the past, we're so glad you're out there, Dr. Hetrick. And early on, she asked a question regarding pathophysiology. Does the degradation of the glycocalyx endothelial glycocalyx layer contribute to the development of lipedema?
Man, I'm glad Dr. Herbst is on here because maybe
Hey, I'm just glad I said that without messing it up too much.
You said that excellently.
Thank you.
Can you
I believe the answer is yes, but I'll let Dr. Herbst, if you want to take this one, if you have an answer.
Can you repeat the question?
I was afraid you were going to ask that. Regarding pathophysiology, does the degradation of the glycocalyx and endothelial glycocalyx layer, EGL, contribute to the development of lipedema?
Okay, so there is no good data showing that the glycocalyx is breaking down in the endothelial layer, but there's a new paper that came out of Vienna, and they showed, like we did, but they used a different assay, that there are small vessels that are leaking. And they actually looked at the tight junctions and used artificial intelligence to show that in lipedema, the tight junctions are not as strong. And so that could relate back to the glycocalyx. I would want Heather's opinion on that. But what was really interesting is they took all of the cells that are in between the fat cells. So they digested away the fat cells from the lipoaspirate. They isolated all the other cells, they grew them up in culture, and then whatever the cells produced and released into the liquid around the cells, they collected that and put them on some normal human endothelial cells, and they leaked. So there's something it sounds like there's something that's being secreted by the lipedema tissue that is causing the leakage to happen. And whether that's damage to the glycocalyx or it's actually just affecting the tight junctions, not sure.
Interesting. Sounds like we could do another whole webinar perhaps on that particular topic. I want to keep going. And
thank you, Dr. Herbst, and that's why she's your medical director, Brenda.
Yeah, that is, and we're so honored and glad. We are really a team. We at Lympha Press consider ourselves an extension of your various practices. We are here to work with you to make life better for your patients. That's why we're in this whole situation. This is why we do this education. And it's thrilling for me because I learn something and I learn how to say new words every time. And here's another one. Chelsea Frond, I think I said your last name properly. Have you ever done work on someone with a VP shunt, a ventriculoperitoneal shunt? A lot of issues are happening around her trunk. And so she has posed that question, VP shunt.
I don't believe I've treated any patients with lipedema who had a VP shunt, but I've operated on patients with VP shunts. So it's not an immediate contraindication, meaning, it's not an immediate no for surgery, but certainly we want to make sure that we have clearance. Like I said, I get clearance from a patient's PCP for every time we go to the operating room. So we want to make sure we have those clearances. And if you have a VP shunt and you see a neurosurgeon or neurologist, we would want a clearance from that physician as well.
Excellent. Angela White, wants your slide deck, and I wanted it too. And you were very, very careful to say that this is protected information. However, we are recording tonight, and everybody who has registered will receive a link to the replay once it's ready and uploaded to YouTube. So you will be able to access it that way. She had wanted it to arm herself with when she goes into medical appointments. So there is a reason why you're not releasing your slide deck, and maybe you can say it better than I can, Dr. Beidas.
No, you said it perfectly. It's there's patient pictures, so I just don't want to share the slide deck. But certainly, if I think the talk, as you said, is recorded, so people should be able to access it afterwards.
I loved how you said that part of your team is going to be including the psychological and the mental health component. You know, we can't underestimate the personal pain that these lipedema patients go through. I've been embedded in the lipedema community for almost 2 years now, and the stories are both heartbreaking and yet inspiring, because these primarily women are very vocal, and they have banded together, which is a wonderful thing. And they've found support in online communities, knowing that they're not alone. Could you just speak for a moment to that component, why you feel that the mental health, addressing mental health issues is important for your team approach to lipedema?
Oh, that's a good question. And I feel like we could talk an hour about that. I think one of the main things with lipedema patients is, and I touched on it a little bit in the presentation. I mean, when you have to see 20 physicians to find out what's wrong with your body or what's going on, with your legs or your trunk or wherever the lipedema is, that's demoralizing and depressing. And probably the 19 guys and gals that you saw before told you to lose weight, rather than try to find a solution or find an answer. So a lot of these women are marginalized or, pushed aside, not helped. And for years and years and years, this goes on. So, I think a big part of it is the mental health, component. And then of course, add on to it that diet and exercise doesn't help with the lipedema tissue. And so that's, demoralizing. I mean, how many women want to lose weight and can't lose weight and don't have lipedema? Now add that other component to it. So, yeah, I think it's really important to include that when we treat women with lipedema. And I think it's telling that that was initially discussed, 70, 80 years ago.
Yeah, it's encouraging to see women that are seeing improvements. You talked about the progressive nature of lipedema, and I interviewed a woman today, just this week. She waited 30 years to get a diagnosis, and she finally got a Lympha press. And after the first treatment, she felt the relief. She felt less heaviness in her legs. That ache that many of these patients deal with was eliminated. And she also noticed less fatigue. So there are tools, and I'm not saying Lympha press is the only tool, but it is a tool that we hope that you will incorporate in your treatment plans. Okay, back to more questions. Kathleen Listen wants to know, are all your PTOTs trained as CLTs, Dr. Beidas?
All of them are certified, yes. Just similar to how, any of the plastic surgeons in the hospital are board certified. So anytime you go to a big hospital system, typically people have to stay in their lane. So it's not like going to the private office down the street. So yes, everyone's certified.
And the incorrect garment used in the brachioplasty?
Like I said before, I don't think it was an incorrect garment. I think it was a combination. Again, I could be misremembering, but I think Dawn also chimed in and confirmed. I think it was not elevating and maybe getting out of her garment too much, or once she got to a certain point where she was so swollen, it got uncomfortable to wear the garment, and so she stopped wearing it. Yeah. And then you have this vicious cycle of swelling and not elevating and more swelling. So it was really just re-education and then getting her into a garment that would fit. So maybe Dawn had to get her something custom or wrap her until she could go back into her normal garments.
Lillian Oliveira, thank you for being with us tonight. She says, thank you so much, Dr. Beidas, for this good information. She wants to know how much compression is recommended after surgery, meaning the grade of compression.
I will defer to my therapist, but I believe 20 to 30 millimeters of mercury is what we recommend.
Okay, got it. Zelda Orenstein, thank you for being with us tonight. Zelda says, sounds like pediatricians could pick up on this early as they see patients in their early teens. And wouldn't that be a wonderful shift where more doctors are diagnosing and noticing it earlier, because hormonal junctures are the triggers. And for instance, the woman I interviewed this week, she saw at age 13, it began right after her menstrual cycle. And she's in her 50s now and finally got diagnosed. What can we do about education? Obviously we're doing what we can do, but.
That's a great point. I mean, absolutely. The most common time of onset for women is in puberty, again, because of that big hormonal shift. So pediatricians would absolutely be the first line or first physician to see this. Typically, I think most pediatricians see patients till they're 18 and some even up until 21. But Brenda, as you so intelligently pointed out, it's an issue of education. So, I saw, I think 3 or 4 women today who were in their 40s and had it, since puberty. So,
yeah. So speaking of education, I love Margaret Williamson's comment. She is planning on taking the standard of care and marching it into her next PCP visit. So good for you, Margaret. And we do applaud and continue to praise and elevate understanding and awareness to the standard of care of lipedema in the United States, a groundbreaking document so needed. She says not many doctors seem to know about lipedema, going back to that education question. Is there a certain specialty like plastics or dermatology that she should seek out to get conservative therapies? What would you suggest to Margaret?
So again, good question. And I think it kind of ties in with what someone else asked about education and how to bring this to the attention of doctors. And I think absolutely taking Dr. Herbst's paper on the standard of care into a physician's office, take a printed copy, walk it in and have them read it, is a good way to get some information out. In terms of the specialty, I don't think I can say that there's one specialty that's necessarily better than any other. I would say vascular medicine doctors seem to know a lot about this, and this is just purely anecdotal. It seems like they make a lot of the diagnoses of the patients that I see. They may not necessarily refer you or recommend all the right treatments. Not that they are going to recommend wrong treatments, but they may not recommend you to a therapist or a plastic surgeon who will treat this, but they do make, in my experience, the majority of the diagnoses. I don't know that there's a great website to look up resources, but I know there's the lipedema disorder website and some physicians on there. But unfortunately, I would not say there's one specialty you can, say, if I go see a dermatologist, they all know about lipedema. It just doesn't exist, unfortunately.
And we at Lympha Press have a network of folks, representatives, compression therapy consultants all around the country. So please do feel free to reach out to me, bviola@lymphapress.com, and perhaps we can connect you with one of the wonderful medical professionals that we work with as well to help you out. We don't believe in just giving you a pump and saying, have at it. We will walk with you. We educate, we try to encourage, and we know that, again, we're just one tool in your toolbox. One final question, Angela White. For exacerbation provided by stressful situations, can you unpack a bit the types of situations that may lead to exacerbation, as well as why that may be so? Now, when I heard you talk about that, I was just thinking just the way life comes at you and the general stressors of life, whether it's, oh no, my dog just did something behind me, to my kid's principal just called me. But is there more to it than that?
I think for the vast majority of patients, again, for the vast majority of women, I had this discussion today with one of my patients because she was in her 50s and she was early stage, really not too bad in terms of symptoms, and she was debating whether it was even worth having surgery. So all that to say, in terms of stressors for women, it's big hormonal changes. You know, the big three will be puberty, pregnancies, and menopause. But, you know, we see women who have, I think I mentioned this in my talk, thyroid issues, and that causes a flare, or need to have a hysterectomy, and that can cause a flare. And then, you know, I would say, again, this is all anecdotal, but some women do say that big life stressors kind of, they feel like it made things worse. You know, again, whether that's true or not, or it's just the natural progression of the disease, and they happen to feel that way. You know, who knows? Again, I'm not sure there's enough data that says that real life stressful situations as opposed to hormonal changes can make this progress. So yeah, I would say hormonal changes probably are what's really driving this. And who knows whether life stressors are driving it or not.
You know, a patient asked, how do I get to be a part of some studies? And I would just say, I know that the Lipedema Foundation has a registry that you can get involved with. And there's such great comments coming in. Dr. Hedrick suggests contacting us at Lympha Press or other groups that provide help for lipedema and lymphedema patients. And we are always interested in whatever trials or studies are going on. Holly Hope says in the United States, clinical trials are registered with clinicaltrials.gov. And then on the topic of stress, Kathleen Listen says, high life events can cause people to stop self-care, change their diet and exercise habits, and throw their schedule haywire. Amen, amen, amen. Whether you have lipedema or not, when you have a stressful life event, all bets are off. And sometimes it just disrupts our normal self-care rhythm. Margaret says, thank you all. Her bariatric surgeon diagnosed her. She is losing weight and hoping conservative therapies will be more accessible as she lowers her BMI. And I just want to thank all of you for your wonderful comments. You made this, aside from Dr. Beidas's excellent material, all of your insights, your comments have been really fantastic. We're so grateful that you took time out of your schedule. And so Dawn apparently is the heroine tonight. What did Dawn do for you, Dr. Beidas?
She does everything.
Dawn, we should do a webinar with you.
Backbone of this program.
Oh, well, we applaud you. We applaud all of you who are researching, studying, educating, asking, advocating. We're with you. And we appreciate you, and we thank you for your time tonight. Any closing words, Dr. Beidas, before we end tonight's webinar?
No, I think kind of like you said, it's a team effort, and we're happy to have Lympha Press on our side, and we're happy to have all the physicians and therapists and dietitians, et cetera, helping our patients.
Fantastic. Thank you. We look forward to having you back for another webinar in the future. And thank you, everyone, for being here. My heart is warmed by your interest and engagement. Have a great night, everyone. We'll see you soon. Bye-bye.
Thanks, everyone.